So I'm presenting a case of Master XYZ, who is 2 years 8 months old, male. He hails from Kodibag, Karwar, Hindu by religion, and he belongs to lower middle class family according to modified Kupus-Farmer scale. The informant for this case is mother, and she is reliable. The educational status of mother is bachelor's in arts. Coming to chief complaints of the patient came with 2 chief complaints. First is cough since 8 days, and after that fever came since 5 days. Coming to history of presenting illness, child was apparently all right 8 days ago. Then he developed cough following playing in water. Cough was acute in onset, non-progressive, more at early morning and night, and was hoarse, hacking type in character. No postural variation of cough was present. There were no aggravating and relieving factors, and there were no episodes of vomiting after bouts of cough. Coming to the history of fever, so patient also gave history of fever since 5 days, insidious in onset, seen during early morning hours and night. It was of low grade type, around 100 degree Fahrenheit upon measurement, and intermittent type in nature, not associated with rigors and rashes, and there were no aggravating factors, but relieved on medication. There were also a history of similar complaints 15 days back, for which the patient visited local doctor. The local doctor prescribed medications and symptoms got relieved. There was no hospitalization done for his complaints. Coming to negative history, there was no history of contact with person of similar illness, no history of contact with any COVID positive or TB patient, no history of running nose, ear pain, ear discharge, and mouth breathing, snoring, difficulty in swallowing, no history of hurried breathing, no history of reduced activity during daytime, altered sensorium, and convulsions. Also, there is no history of irritability, excessive crying, decreased food intake, loose discoloration of lip and extremity, and also no history of vomiting and diarrhea. Coming to past history of patient, there's no history of previous history of similar complaints in past, and also there's no history of hospitalization or nebulization in past, and no history of any congenital anomaly detected at or after birth. Coming to antenatal history, the child is first child, booked case, detected by urine pregnancy test at 2 months of amenorrhea and was confirmed by ultrasonography. Coming to history in trimester wise, first trimester, there was no complaint of fever with vesicular eruptions and drug or radiation exposure. Regular ANC visits were undertaken. Second trimester, quickening was felt at 5.5 months. Regular ANC visits were done, and there were no history of any complaints suggestive of pregnancy-induced hypertension or gestational diabetes mellitus. Coming to third trimester history, the mother continued to perceive fetal movements. Regular ANC visits were done, and there was no history of any complaints suggestive of gestational diabetes mellitus or pregnancy-induced hypertension. Coming to natal history, normal full-term vaginal delivery was conducted at hospital. Birth order 1, cried immediately after birth. The birth weight of the baby was 2.6 kg. BCG, OPV, hepatitis B vaccine, and vitamin K was given. Breastfeeding was initiated within 30 minutes of birth, and there was no history of any NICU admission. Coming to neonatal history, the neonate passed urine and meconium within 24 hours of birth. No prelactal feeds were given, and the baby was exclusively breastfed, and baby used to sleep 2 to 3 hours after feeding. And there was no history of any yellowish discoloration of skin and sclera after within 24 hours of birth or in neonatal period. Coming to diet history, the diet history of patient was taken in 4 parts. It was taken by 24 hours recall method prior to the time when patient developed illness. So the diet history was taken in 4 categories: morning, afternoon, evening, dinner. So in morning, the patient used to consume Mangalore buns and sambar. So 1 Mangalore bun and half cup sambar, which corresponded to 245 kilocalories and protein intake of 7.2 grams. Afternoon, rice and sambar, 1 cup of rice, 1 cup of sambar, that corresponded to 391 kilocalories and protein intake of 13.7 grams. Evening, cow milk, 1 cup, 163 kilocalories, 7.8 gram of protein. And in dinner, the patient took chapati and mixed veg bhaji, 1 chapati and 1 cup of mixed veg bhaji that corresponded to 221 kilocalories, protein intake of 5.9 grams. So upon calculating the total calories consumed, it came to be 1021 kilocalories, and the calorie required for this age group is 1060 kilocalories per day. So the calorie deficit in this case is 39 kilocalories, which corresponds to around 3.6%. Coming to the protein consumed, the patient used to consume 34.6 gram of proteins, and the protein required in this case is 13 grams. So here there is no protein deficiency. In fact, we can say protein excess is there. And sir, the patient in this case is vegetarian, so there is no history of any non-veg intake of to confirm any excess protein intake. Coming to developmental history, so the developmental history was analyzed in 4 domains: gross motor, fine motor, social, and language. Coming to gross motor domain, the milestone achieved was the child is able to run, kick ball, and jump on the spot. And the expected age of attainment of this milestone is 2 to 2.5 years. And the child attained this milestone at around 2.5 years. That gives development quotient to be 1. Coming to fine motor, the milestone achieved is turn 1 page at a time, unscrew lids, and same, the expected age of attainment was 2 to 2.5 years, and the observed age of attainment was 2.5 years, and again development quotient is 1. Social, goes toilet unassisted and plays with peers. So this milestone is achieved at 3 to 3.5 years, but here in this case, the child achieved this milestone at 2.8 years only. So the developmental milestone, development quotient comes here as 1.16. Coming to language, the child asks questions, knows full name and gender. Here also 3 to 3.5 years is the expected age of attainment of this milestone, and the child attained this milestone at 2.8 years of age. So the development quotient comes here to be 1.1. So overall, we can say that the developmental milestones are achieved corresponding to chronological age. Coming to immunization history, sir. At birth, the child received BCG, OPV, and 0 dose, and hepatitis B first dose. At 6, 10, 14 weeks, the child have taken OPV first, second, third dose, pentavalent vaccine first, second, third dose, fractional IPV at 6 and 14 weeks of age, and rotavirus vaccine and pneumococcal conjugate vaccine was not taken. At 9 months of age, the child took measles rubella vaccine along with vitamin A, and at 16 to 24 months, the child have taken measles rubella vaccine, OPV, and TPT booster dose. So, sir, till now, the child is immunized up to date. Coming to family history, mother is housewife, father is auto rickshaw driver. Both mother and father are literate, and child is born out of non-consanguineous marriage with mother's age at time of birth 25 years and father's age 28 years respectively. There's no history of similar complaints in parents or any other family members, and there is no history of asthma, TB, allergy in family. Coming to environmental history, sir, they live in Pakka house, 3-member family, adequate ventilation, municipal water supply, sanitary latrines, and they use LPG gas cylinder for cooking. There is no history of bottle feeding in the child, and there is no history of smoking in home or use of chulha for cooking. And also there is no history of seepage of water. So I would like to summarize.
Leave that, Anjali. Get back to your first slide. Back to your first slide.
This
Very
one,
good. Sir? You stay with the chief complaints.
Okay.
Now, if you were there in the first 3 days, then there was no fever. There was only cough. Now, suppose this child came to you on day 3 without fever. What was your thought process? Now, before we get into discussion, please remember that the first question to be answered on the history analysis is, where is the anatomy of the disease?
Yes.
Which means the site of the disease. Yes. And not only anatomy, but microanatomy. That means in the respiratory tract, where is it located? That's number 1. Once you know that, you discuss what could be the pathology. And then you make a guesswork of etiology. And finally, you give a diagnosis whether there is any functional impairment of the affected organ, right? So
Yes,
now,
sir.
first 3 days of cough in a 2 or 3 month old child, where is the anatomy? Now, you did start saying that you are going to present a respiratory case. Now, how are you sure at that time whether it's a cardiac case or a respiratory case? Even cardiac case has a cough, right?
Yes, sir. True.
So how did you arrive in the first 3 days? Okay, where that is a respiratory problem.
Sir, first of all, cardiac case usually does not present with such a short history of cough, sir. Like here, the history of cough is very short and it is associated with fever. And the fever is also of mild type. So cardiac case, mainly they will complain of breathlessness also. But here, the child is not having any breathlessness as complaint.
Good, but we are not discussing fever as yet. I am on day 3. I do not know whether this child will get fever. So
Yes.
I have only cough. Now, cough could be a cardiac as well, right?
Yes, sir. But
so then why are you considering it to be only respiratory and not cardiac? Any other, I could see Sagarika there, Sachin there. Okay. Anybody who wants to know, you can even put on your video. We can see you. Anyone wants to talk? Okay, Anjali, you tell me why not cardiac?
Sir, cardiac will mainly present with chronic cough or like it will be recurrent episodes of cough, sir. But
Very
here,
good.
sir, we are just getting the chief complaint as coughs inside days. So when we think only as cough, the first thing that comes to our mind is respiratory cause, sir. And afterwards, we think about serious and other cause. So the first thing that came to my mind after seeing coughs in 8 days was it can be probably due to respiratory cause. After I rule out respiratory, I'll go to serious and other causes.
Very good. But keep in mind that when you have a cough as a presenting symptom, okay, why not this to be cardiac? Acute cardiac conditions do not present with cough, they present with breathlessness.
Yes.
And sometimes the chronic cardiac person may have a cough as a presenting feature, and on direct questioning, he might say he is also a bit breathless. So
Yes.
the acute presentation of a cough is almost never cardiac, and therefore this must be respiratory. But I will put you another possibility that it could be because of the gastroesophageal reflux that this
Yes.
child aspirated and started coughing. Now rule that GER as a probability of this cough. And then I will accept it's respiratory. Of course, GR is also respiratory when it comes to cough, but the cause is extra respiratory.
Yes.
So why not GR?
Sir, GARD also, sir, it will not come with such acute history. And sir, in history of presenting illness, we have ruled out GARD. Like GARD will have, like suddenly it will not start, slowly it will come. And other features will also be present, like heartburn.
Very good. So what you are trying to say is that first, GRD could present with an acute onset cough when he suddenly aspirates, but that presentation is with choking spell. There is a choking spell and a cough, not just a cough. And when the cough is the only presentation, there is a micro aspiration and therefore is going on for some time. And lastly, we need to look at whether this child is a candidate for such a GERD, and he has grown well, he has had a good nutritional intake. So here is a healthy child and past 2 years of age. So it's almost ruled out that this cannot be a GERD, and therefore I'm convinced it's a respiratory tract. Now tell me, in a respiratory tract, you have 4 parts of the respiratory tract for a clinical bedside analysis. One, airway disease. Second, a lung parenchyma. The third, the pleura. And the fourth, the interstitium. There are 4 clinically relevant parts of the respiratory system. Which one are you thinking about, this child's anatomical or microanatomical site?
Sir, I'm probably thinking it to be airway, because the first thing we will rule out lung interstitium involvement. By in interstitium involvement, usually the first complaint will be fever, and followed by cough will come. Here, first complaint was cough. So probably it is airway disease, and it is associated with some allergic inflammation of airway, allergic or any etiological.
Excellent. I think you are bang right. But first tell me, even a pneumonia may have a mild cough, right? So why did you not anticipate it to be due to lung parenchyma?
Sir, pneumonia will also have complaint of breathlessness, and the fever will come first. After that, cough will start.
Very good. So pneumonia does not present with cough, present with fever and breathlessness, and the cough is a minor symptom to begin with. So what have you learned? When there is a cough, ask some details. One, whether cough is severe or only mild. And is the cough a presenting feature? Then it's an airway disease. Now, having said airway disease, Anjali, you are doing so good. Tell me, is it an upper airway disease or a lower airway disease? By upper airway, I mean right from nose up to the trachea maybe, and down bronchi onwards is the lower airway. What do you think?
Sir, based upon chief complaints, sir, if it is upper airway disease, then it should have some chief complaint related to like nasal discharge or throat pain or any symptom like that. But the child have not said anything like nasal discharge or throat pain. Like it will also come in chief complaint if the child complains of that. So the child have not complained anything like that. And so based upon that, I probably think that the lower respiratory tract is involved.
Very good. So the major difference between upper airway and lower airway cough is upper airway cough is a dry cough. And the lower airway cough is a wet cough. Okay, that's a major difference. But you have been reasonably correct, but add the word dry cough or a wet cough. And in a young infant or a toddler, the wet cough does not equate to a cough with expectoration. In a bigger child or an adult, you ask for the history of cough with expectoration, which becomes a wet cough. But a small infant or a young toddler cannot expectorate, and therefore all that we ask the mother is whether the chest is very noisy, indicating that very likely it's a wet cough, and that's how you differentiate upper airway from lower airway. Now you are right that this child started with an airway disease and now he gets fever. Now, what is this cause of fever?
So the cause could be any supersided infection.
All right. Okay. So now tell me that does viral infection start with a fever or fever comes on day 4?
Sir, viral infection usually starts with fever.
Starts with fever. So this is behaving something differently, right?
Yes. Yes.
We take a note of that. Of course, one possibility is whether the fever has been mild anyway, and whether a mild onset of fever along with cough has been missed, and now as the fever increased a little, 200 degrees, the mother noticed that the child also has fever. But keep a note that typically a viral infection starts with fever and cough almost together, and also often has cold. Now this child doesn't have a running nose, right? No. So there is something which is little odd, but yes, that is the commonest cause, and we keep that in mind. But suppose it is not so, then do you think it's a secondary bacterial infection?
Sir, based upon chief complaints, we can probably think it is secondary bacterial infection because we don't know how much is the fever.
Very good. So what you are trying to say, in other words, is secondary bacterial infection is common when there is a stagnated secretion somewhere, like a bronchiectasis, like a sinusitis, Okay, there is a stagnant secretions, and that becomes an easy nidus for the bacteria to come in. Now, this child doesn't seem to have any of that, and therefore it is unlikely that it is any bacterial infection. So far, so good. But now tell me one more thing. Could it be a tuberculosis because you have a low-grade fever? So
But,
what do you think?
but tuberculosis will have chronic cough, sir.
Yes, but Anjali, you're right. But chronic cough begins as an acute cough someday, no?
And so
Now,
in such a short duration, we cannot
yeah,
think of tuberculosis.
agreed. See, Anjali, you are so good that I want you to diagnose a chronic cough in the first 2-3 days and tell me that, oh, this is likely to be chronic. Wait for a month. Okay. So you agree that chronic condition must start one day as an acute condition. And when it goes on and on beyond 2 weeks or so, you call it chronic. So what makes you say that this is not likely to be TB at all?
Sir,
Anyone else on the live platform who wants to also pitch in? Anjali is doing extremely well. Okay. I'm sure she will answer all questions that I put up. But is anybody else ready to help her out or also participate? Okay, now tell me, Anjali, why not TB? Low grade fever. Okay, cough. TB is a national disease, right? Yeah. So why not consider that?
sir, fever should, like, we can consider it, but based upon history of presenting illness, it will get ruled out, sir. Like, based upon chief complaint, we know only cough since 8 days, fever since 5 days. So based upon that, we can consider it as a differential diagnosis, but in history of presenting illness, it will get ruled out.
Fine.
The history of tuberculosis, contact history should be present in case of TB.
Very good. But you know that contact may not be evident. You are right, absolutely. Now, somebody else has said that there is no weight loss, but for weight to be lost, there has to be some time. Okay. So, all that you say is that there is no reason to suspect TB in this child because he has been healthy. Parents have been taking a lot of care. You gave a history that there was an antenatal periodic checkup. Okay. You gave a history that all vaccination, most of them have been done. And you also said that they are quite educated. So they are taking extremely good nutrition is excellent in this child. So they are taking good care. There are only 3 of them there. Therefore, very likely there is no TB contact. He is very healthy and we will not to begin with consider anything of that kind. Fine. So now we said that bacterial infection looks unlikely. TB we will not consider at this point at all. But for viral infection, we are a little concerned because the fever came on day 4 of the presenting symptoms, and that's something unusual. So now, could it be simply a hyperreactive airway disease, allergic airway disease? What do you think?
Yes, sir, it could be, but here we have only one episode of cough. So based upon one episode of cough, we cannot diagnose it as hyperreactive airway disease.
Okay. And therefore, we keep all these options in mind, but you gave a history that 2 weeks prior, there was a similar episode, right? Now tell me that, would you think the viral infection is repeating within 2 weeks in this child? And possibly he is mostly at home and he has been well looked after. There are no other aggravating factors, contact factors. Therefore, do you think that could have been an allergic situation and now this is also allergic situation?
Probably, sir, but the viral infection was just 15 days back. Maybe the infection have not subsided still, and again it got aggravated. So based upon 15 days history telling as reactive airway disease.
Very good. So the main reason is allergic respiratory problems are very rarely going to present with infection. Infection can aggravate allergic response, but not the allergic condition causing an infection. And therefore, we stay with what we have discussed so far. And therefore, now show me your summary slide. Let's see what. But before that, just go up one by one slide. I have some questions for each slide. Next slide. No, this was all right. Next one. This is also all right. Next one. Fine. This is also fine. Next one. Okay. Go ahead. Okay. Now, when you ask negative history, you are right. You have put all possible statements in the negative history. But remember, negative history has to be as short and relevant as possible.
Yes.
What do you mean by relevant? Negative history should be such that the parents are likely to forget to report to you. For example, if there is a altered sensorium or a convulsion, they won't forget to tell you that. In fact, they would come out first with those symptoms. Same thing, if they've observed the bluishness, they would come running to you. So your negative history should be such that the parents consider those symptoms as so minor that they even don't report to you unless you fish it out. For example, in this child, you wanted to possibly ask, is there any running nose, blocked nose, open mouth? You did ask that because for them, that little cold is of no concern. But for us, that is important because we will know that it's also the nasal airways which are involved. So you are right in mentioning all this. Like, suppose this child is breathless. That would be their first symptom. They won't forget breathlessness. They won't forget the convulsion. So they won't forget diarrhea, vomiting. Okay. So keep the negative history short and relevant. Well, sometimes the relevant negative history could be long, but generally that is what it is, right? So that is fine. Go ahead. Next slide. Yeah. Now, okay, all right. That is fine. Go ahead. Fine. Antenatal history is also good. Go ahead. Even third trimester is fine. Go ahead. Fine. This is also good. Go ahead. Fine. Next. Yeah. Now, when you come to this, you have done an excellent job of 24 hours call and all that, and you have done it so perfectly well. But when you say that lastly, calorie deficit is 39 kilocalories, okay, you consider it as almost no deficit.
Yes.
Because these are not the numbers that each one of us must achieve. There is a spectrum. And if out of 1,000 calories plus calories that this child requires, if 3% calories are not enough or deficient, then I suppose we call it normal, right? You're fine.
Sir.
But now tell me about proteins. This child is consuming too much of proteins.
Yes, sir.
Okay. Now, two things are important. One, in an average diet that we all as Indians take, it's not easy to go with a high protein diet unless you just take a lot of non-vegetarian food with high protein. Yes, I'm sure this child did not do that.
No,
so when you come to that high protein, there could be some miscalculation. For example, when you said that in the morning the has sambar or at afternoon has sambar, we don't know how thick that sambar is or how watery that is, and you are calculating with some idea of how much proteins that must be having, and take a note of that. Okay, so achieving double the proteins or more than double the protein is not an easy proposition in most of the Indian diet. That is number one. But second question related to this is, do you think it is harmful to take so much of proteins?
Sir, excessive protein can be harmful. As we say, excess of anything is harmful. So excessive protein can be harmful, sir, but 34.6 I unlikely to be harmful in this case, because children usually play and are very active. So
Fine. So the point I'm making is, one, when you say protein content of this child every day is almost double the requirement or even more than double, I start wondering whether there is some miscalculation. That is number one. Second is, such a high protein consumed is likely to damage the kidneys.
yes,
Because ultimately kidneys have take a note of all that, and when the digestion and absorption occurs, the liver converts it into ammonia, and then finally kidney does it into urea. So kidneys are likely to be burdened with extra work and likely to cause some chronic renal dysfunction. In fact, Dr. Atkinson's diet for obese people to reduce weight consisted of an extremely high protein, and quite a few of them died in the process of reducing weight. Okay, so take a note of it, because I'm pointing this out because you have done so wonderfully well. I'm impressed by every statement that you have made so far. And the way you put up a diet chart was so good. But take a note, sometimes when you get a result of something that is not a common expected finding, in that case, you always consider that there could be some error. And you know that sometimes the laboratory who reports something very unusual makes an asterisk and say that it is doubly checked, because they have taken a note that it's something unusual, right? So do that. Okay, next slide.
sir, yes.
Fine, this is also fine. Very good, excellent. And now tell me your summary straight off.
Okay. This is fine, sir. Immunization.
Fine, fine. Everything else is fine. Okay, good. This is also good.
Okay.
Yeah.
Summary. So coming to the summary of the case history. So this is a case of 2.8 years old boy, born out of non-consanguineous marriage, birth order 1, full-term vaginal delivery, belonging to lower middle class according to modified Copeaux-Formé scale, presents with cough, which is hoarse, hacking type in character, with increased severity in early morning and night hours from 8 days, associated with fever since 5 days, which is mild and intermittent type seen during early morning and night hours. Also, there is history of similar complaint 15 days back, treated with medications on OPD basis, developmentally normal and immunized till date. So based upon the case history, I suspect lower respiratory tract infection, probably of viral etiology.
Very good. Excellent. Now, just to make the summary as short as possible, okay, what could you have made a short form of all this? You could have said that a healthy child, right from birth up to now, that means everything is covered, has a cough suggestive of an upper airway disorder going into lower airway with infection that looks like a viral infection. I've almost covered everything. You have given all the details. Okay. Now tell me, what is this hoarse hacking cough means? Where is the anatomy?
Airway and hoarse hacking means basically dry, like it sounds dry type. It involves airway, sir. Airway involvement is there mostly, and this type of cough is mostly seen in upper airway involvement.
Very good. And typically hoarse cough or voice indicates a laryngeal involvement.
Laryngeal involvement.
All right. So you can almost upper airways also talk whether it is pharynx or larynx or even rarely trachea itself. So this looks like definitely upper airway, and the question is, why is it only in the night and early morning?
Sir, at night and early morning, the temperature is usually lower when compared to afternoon time, sir. So due to cold, it may get precipitated. And sir, in early morning, we can, if we talk of night, increased night, so in asthma or any bronchial involvement, we see night cough and night fever.
Okay. See, most of the coughs are worst on lying down position. Okay, because you have a lot of relaxed muscles and your abdominal pressure over the diaphragm might make even your breathing to the minimum. And to that extent, you always find the cough bothering them more often at night or early morning. But as you rightly said, that typically episodic nocturnal cough is a characteristic of a bronchial asthma, and we cannot label this child as a bronchial asthma at all. But this child seems to be developing some symptoms simulating, and that's why when you counsel this patient, parents, you might have to tell them whether you anticipate a recurrence of cough, and they need not worry about it. We can always take care of it. So some anticipation could be possible, which will help us in counseling, right? Let's see the physical examination.
Okay. So coming to general physical examination, the child was alert and playful, examined in adequate lighting and exposure after obtaining mother's consent in sitting position. The first vitals, the pulse was 99 beats per minute, regular rhythm, normal volume, no radioradial or radiofemoral delay. Temperature was 99 degrees Fahrenheit. Respiratory rate was 24 cycles per minute. Blood pressure was 85 by 60 millimeters of mercury over right brachial artery in supine position. Coming to anthropometry, sir. So the parameters were taken into consideration are as follows. First, weight. The observed weight of the child was 11.8 kilograms. And the expected median for this age group, according to WHO growth charts, is 13.1 kilograms. So the child weight lies between -1 standard deviation and median. Coming to height, the observed height was 91.5 centimeters. Expected median is 92.2 centimeters. Again, above -1 standard deviation, around median. Head circumference was 46.5 centimeter. Expected median for this is 48.1 centimeter. Here the head circumference lies lower than -1 standard deviation. Chest circumference was 52 centimeters. Mid upper arm circumference was 15 centimeters. And the expected median for this age group is 15.6 centimeters. So the mid upper arm circumference lies above -1 standard deviation, around median. And upper segment lower segment ratio came 1.5:1, and expected median also 1.5:1. So it also lies within normal limits. Coming to head to toe examination, skull was normal, shows spontaneous. Hair was black, no color changes. Eye, no pallor, icterus, KF rings, bite or spot, and dryness. Ear, no discharge was seen. Nose, no nasal flaring, no septal deviation of nose. Lips, no cleft lip, no cyanosis. Oral mucosa, normal mucosa is there. Tongue, no cyanosis, appears to be normal. No cleft palate, and normal dentition is present. Neck also appears to be normal. Nails, no clubbing. Skin, no skin changes are there. Abdomen and genitalia is normal. Spine and back is also normal. Lower limb is normal. And also there is no edema or lymphadenopathy. Coming to respiratory system examination in proper, nose had normal septum, no nasal flaring. Oropharynx appears to be normal, no tonsillar enlargement. Coming to lower respiratory tract, upon inspection, the chest appears to be elliptical in shape, symmetrical on both sides. Normal chest movements equal in all areas. Trachea appears to be central. Apex feet is not visible. And there's no subcostal or intercostal indrawing of chest and no dilated veins on chest. Coming to palpation, there's no local rise of temperature, tenderness, or crepitus. Central position of trachea. Apical impulse was felt at fifth intercostal space in mid-clavicular line. And there was decreased chest expansion on both sides. And so tactile vocal fermitus could not be elicited. The child was not cooperating for it. Coming to percussion, normal resonant note was heard in all lung fields. Coming to auscultation, vesicular breath sounds associated with bronchi was heard in all lung fields. Other system examination, cardiovascular system, S1 and S2 was heard. For abdomen, no hepatomegaly or splenomegaly. CNS, higher mental functions were normal and there were no sensory or motor deficit. So based upon history and examination, I come to the diagnosis of persistent lower respiratory tract infection involving bronchioles of viral etiology. Sir, you are muted. Sir, you are muted. Hello, sir. Sir, you are not audible. It's muted.
Yeah, now can you hear me?
Yes, sir.
Yeah, the host was not allowing me to. Okay, good. I was wondering why I was not. Just go back 2-3 slides. Go back 2-3 slides. Go back one. Go back one. Yeah, stay there. Stay there. No, one more. Yeah, stay there.
This one, sir?
Now, you have said that there is a decreased chest expansion on both the sides.
Yes.
Okay.
Sir.
That's abnormal.
Yes, sir.
So why is the decreased expansion on both sides?
Sir, it could be like the severe cases which we think in this case is, sir, any collapse of lung lobes or any pleural involvement, but history is not suggestive of anything of that sort. So maybe due to airway involvement, inflammation, the baby is not able to breathe.
Okay. Now, anyone else? I can see Sagarika there. I can see Vivekanand. I can see Sachin. Would anyone tell me what must be the cause of decreased chest expansion on both sides? So it's not a localized problem, it's a generalized problem.
Yes.
And the reason is there must be some retained air, like an emphysema. Okay, that means the inflow and outflow of air is very minimal, and this suggests, and then you have a scattered bronchi all over. So there is an evidence of a bronchial obstruction, and when there is a bronchi, which is an evidence of a lower airway obstruction, the inspiration is very active process. You suck the air in, but the exhalation or expiration is a passive process. So the obstruction comes in the way, and not all air can go out, and that is why a patient with an emphysema has a very decreased expansion, and therefore this child seems to have a generalized bronchial obstruction, lower airway obstruction, and possibly some retained air, though you have not seen on percussion the hyperresonant note. Okay, but sometimes when the percussion note is equal on both sides, it's not so easy to pick up whether it's a hyperresonant or just normally resonant. So now my question to Anjali is that what are the signs, percussion signs, to suggest emphysema?
Hyperresonant
all right,
note.
What else should be there?
On percussion, sir.
Yes. And two more things. The heart border looks to be smaller now, and the upper border of the liver is pushed down. Okay, because that is important, right? And therefore, sometimes when you have a bilaterally equal resonance, it's not easy to call it normal or a hyperresonant. And I'm sure sometimes when in a CNS child you are looking at the tone of the muscle, you might feel, oh, this is a bit hypotonic or this is a bit spastic, but that is close to normal. So sometimes this problem comes, but you have already picked up a decreased chest expansion, and that suggests that there is some air trapping. If there is an air trapping, yes, you have an evidence of a scattered generalized rhonchi, which suggests a uniformly affected lower bronchial obstruction. And to that extent, your diagnosis now shall tell me your final diagnosis in this child.
Shall I change the slide, sir?
Go ahead. Show me the final diagnosis. Yeah, that's right. Very good. Okay. Now, at this point of, tell me, do you have any more slides to show me?
No, sir.
No. So just stop sharing slides and let's have some discussion. We have 10 more minutes to go by and we will stop on time. Okay. Now,
just a second.
Very good. Yes. So now let some more people come on the scene. Okay. So Sagarika, Sachin, Vivekanand, okay, you can put on your video if you like. Anjali has been excellent in answering every question that I put up. Okay. And I'm sure some of you also put your views on the chat. So now I want Anjali to tell me that would you investigate this child?
Sir, for such an acute history and like no complications are present, we don't need any investigation. Like clinically, we can diagnose. But if for let's say CBC, we can do. Just X is not required in this case.
So don't you want a CBC, ESR, CRP, then chest X-ray, or you want none of that?
Sir, that much investigation, because we can easily clinically find out what the child is facing. So I don't feel we need investigations at this stage.
Excellent. You are a perfect rational doctor. What does it mean? You will not unnecessarily do some tests because the tests are available. Okay. This child does not need the test. Okay. Why? Because one, a clinical impression seems to be fairly strong, also supported by examination findings. Child is healthy. Child is not breathless. So we have a reason to wait and watch further progress. There is no hurry to get to some investigation. And I'm so happy that today's world, everybody talks about evidence-based medicine. Everything has to be evidence. But experience and evidence are the two sides of the same coin. When experience tells you there is no need to search for an evidence, for example, if somebody asks you, when you go on the top floor of the building and jump, do you think you will break the bones? He said, no, I don't have any evidence. So what evidence do you want? A simple logic or common sense tells you. So I'm so happy that you did not want any investigation at all. Okay, but suppose this child keeps on coming to you every month for the next 3-4 months. Now would you start wondering whether you should investigate?
Sir, in this case also we will get one chest X-ray and basic blood investigations first, and after that we will proceed further based upon that number.
Very good. So now I'll make one strong point for you to understand further. When there is a recurrent problem of any kind, we want to know whether the disease is persistent or the disease is recurrent. Now, I give you an example of a persistent disease with recurrent cough or fever, and that is tuberculosis. In tuberculosis, you get fever off and on, right? That is a persistent disease with recurrent symptoms. But in a typical viral infection, which can repeat n number of times, there is a recurrent symptoms in a recurrent disease. Now, how do you find out the difference between a recurrent disease and a persistent disease? Both can have recurrent symptoms. So, yeah, go ahead, Anjali. You are wanting to say something. I know you are thinking of something good. Tell me.
Sir, first of all, in persistent disease, we will ask about the treatment history. And we will first check whether the patient was compliant with the drugs or not. We'll check that. So sometimes what happens is mostly due to non-compliance of patients to drugs, that infection persists, and due to that symptoms comes again and again. So first we will check that and we will rule out whether it is persistent or not. And after that, we will go dig further and we will ask like how many times in a year and what are the symptomatology and all. So basically recurrent infection means like more than 3 times in a year with radiological clearance. But persistent infection means like it could be n number of times in the same month, but without any radiological clearance. So first we will check compliance and all, and after that we will proceed further to dig out whether it is recurrent or persistent.
Wonderful. See, I know you are all so intelligent people that I put up a question and your gray matter starts working so well. But I'll add on something more important. What you said is perfectly right. Okay. But the major difference is a child with a persistent disease with recurrent symptoms is getting more and more constitutional symptoms, which means he is not eating well, he might have lost some weight, or he feels tired, or a child doesn't want to play. So some constitutional symptoms which are hidden in between those recurrent symptoms. But if there is a recurrent problem with a recurrent disease, the parent would say, no, as soon as the child gets well, oh, he is jumping about, he is running about, he is eating well, he looks totally normal. And therefore, if somebody gets a recurrent problem over 6 months, 3 times, if it's a recurrent disease, that child has not lost weight even at the end of 6 months. But if it's a persistent disease, child certainly has lost some weight, and that also is seen by a personal history of behavior, appetite, sleep, happiness, activity, all that. And that is the major difference. But you said many of those points are absolutely right. But again, for a radiological clearance, you must note 2 things. A radiological clearance takes sometimes weeks. For example, you have a pneumonia. A pneumonia gets better within 4 to 7 days, is cured within 7 to 10 days, but the radiological shadow may persist for a few weeks. So radiological shadows take a longer time to disappear, but the clinical recovery is much faster. So that may not be a strong point, but yes, you are thinking in a right direction. But I gave you a simple formula that one is going down in health, the other is maintaining health, right?
Yes.
Now, lastly, how did you treat this child?
So here we will give symptomatic treatment only because viral diseases are self-limiting only. So here in this case, we will give paracetamol for fever to subside. And also we can give bronchodilators like salbutamol nebulization for bronchial clearing and bronchodilation. Other than that, antibiotics and all we definitely don't need here. Other than that, nothing else I feel.
So good, perfect. But because you are so good, I am going to put you some funny questions each time. Okay, so that you can be even better than good. Okay, and that is best. So now tell me that you said you will give paracetamol for fever and you would give bronchodilator because there is a bronchospastic cough. Okay, now tell me, does every fever needs a paracetamol?
No, sir.
Then
Fever
which fever needs paracetamol?
Sir, like fever which is reoccurring like more than 2-3 times. Like fever is basically a response of our body to allergens. It's a good sign, sir, but not always we need paracetamol.
So now tell me, when this child has come with 100 degrees fever, right? Do you want to give him paracetamol?
Yes, sir. Duration is from 5 days.
The duration may be anything, but so the point is paracetamol for fever or any painkiller or bronchodilator are all just symptom relieving drugs, right? So first it depends on what is the symptom. So now tell me, is the fever a symptom? We'll say yes. But for the patient, the discomfort caused by fever is a symptom.
Yes, sir.
So now, if you have a little headache, for example, I'm almost talking to you for 1 hour, you might have started a little headache.
No, sir.
You don't have to take a painkiller because that headache is tolerable. So what do you understand? A painkiller never kills pain. And it's called painkiller. Painkiller makes your pain tolerable. But if my pain is already tolerable, what can the painkiller add to that? Same way about fever. If fever is causing significant discomfort, which means child is irritable, cranky, because of body ache, headache, he is lying listless, okay, then you give paracetamol, the fever may come down only a little, but the behavior is changed, the discomfort is changed. So all symptom relief drugs need to be given with a counseling to a parent to say that, look, I'm giving you paracetamol, but don't give if the fever is not disturbing your child. But often the fever is disturbing to the mother. And therefore she says, no, you must do something. No. But now, is the fever useful for the body? Why is God so unkind? God is unkind. Why fever? Why pain? So what does fever do? Give me discomfort. Is fever of some benefit to me?
Inflammatory reaction of a body. It shows how well your immunity responds to the infected.
But why fever? Okay. For example, if I get angry, I respond. And by that, I am hurting myself. I must learn how not to get angry. So why do we do that? So fever is a friend, not a foe. And how does the fever help? When there is a fever, there is an increased blood supply to the site of the disease. And along with that blood comes the defensive cells, the immunoglobulins, all armamentorium to fight. And that is how the disease is contained and it helps to heal the child. But if fever is causing discomfort, we must relieve discomfort but not relieve fever. So if 102, 103 fever, the child is very restless and irritable, I want to give paracetamol, and the mother would tell you, sure, the fever has still been there, but it has been now come to 100. So to which I would have counseled the parent beforehand to tell her that the fever may not get back to normal, but the behavior will change and he will look a little better. So paracetamol is given to relieve discomfort and not to relieve fever. You get the point? Same thing about bronchodilator. Okay, because when you give a bronchodilator like a salbutamol, it will dilate the bronchi, but it will cause tachycardia, it will cause cerebral irritation, and therefore, when one site gets a little better, it is at the cost of other sites getting disturbed. So I want to know whether the bronchospasm is making the child breathless, not able to speak, not able to walk about, not able to run about, then I might give it. But otherwise, I would avoid it. And lastly, when you have a headache, severe, you take some analgesic, but where do you put that analgesic? In the stomach. But you can't put it in the head. So now what happens? The headache is relieved, and now I start getting burning sensations in my stomach because that NSAIDs, analgesic has caused irritation of the gastric mucosa. So now I go to the doctor and say, sir, thank you. My headache is gone, but now my epigastric pain has started. What good did you do? So remember that. So what do you mean? The last thing is, if possible, use the locally acting drugs. And Can you use a locally acting bronchodilator?
That nebula inhaler.
Excellent.
Inhalant, sir.
So
Inhaler.
inhaler or nebulizer has a very small dose, acts locally. There is very minimal systemic absorption of a drug, so there is no side effect. And you know what is side effect? Side effect is effect of a drug on side organs. So when I am relieving the bronchial spasm, the side organs like the myocardium and the cerebral cortex are getting the effect of a drug. That is side effect. Now, whose side are you? Only the side that is involved, right? Yes. So learn to give drugs, symptom relieving drugs, SOS, and not 3 times a day, 4 times a day, every 6 hours. That is totally wrong. And give it locally acting if possible. Right? Good. I think we are just 8 o'clock. Anjali, I am mighty impressed by 2 things. Not your knowledge alone, but your confidence that you have a knowledge. Now, many people who have a big knowledge are very diffident. They go to the exam saying, oh, I am afraid I am going to fail. And finally, they may come out to be first also. You are confident and knowledgeable. And lastly, your presentation was so clear, so crisp, and your delivery of tone, pitch, pauses, excellent. I think I would have given you more than 100% mark if there was any. Yeah? Good job done. I'm very happy. And I think back to organizers, we have finished and I've enjoyed talking to Anjali and seeing her presentation.
I envy you, Ms.Anjali. I envy you. Okay. To get such a good appreciation from a legend, it's a great achievement. Now, more than you, see, this session was not just for the students, but also for the teachers, how to teach, how well we can do, how even, so to tell more about this, I won't tell. We have another legend herself, okay. She's also one of the best pediatricians our India ever seen, author of multiple books. She's my teacher to one of my favorite teachers, Professor Asha Venkappa Madam from Bangalore Medical College. So she has joined us, she has listened to the entire class, and she's the one who commented about the Amdekars are so nice. See, being a legend herself, she has commented, Amdekar sir, you are such an epitome of knowledge and yet so humble. See, this is what we learn. Go up and up to become the best teachers.
But I must tell you that people like Anjali also teach me, because she would ask some question. I have to explain to her the way she has understood, which means I keep on improving myself. Okay. And if such student did not come in front of me, I would not have learned how to teach also. So I must say that when a teacher teaches a student now, you don't forget that you also are teaching a teacher. But
yes, sir.
Conventionally, teacher has to teach a student, but I am sure I have learned so much over the last 55, 60 years. I have learned so much for students like you. For example, I learned today how to be so confident at an early age. Excellent. Very good. Thank you very much.
Author of multiple books. And now I would request Asha Venkappa Madam to some concluding remarks about the case, presentation, and also the whatever your insights, Madam. Please.
See, when Bhishma Pitama, like Dr. Ambedkar has discussed, I have nothing to say. You know, wherever Amdekar sir is taking a class, I quietly sit and listen to it because it is so amazing. And every time when I listen to him, I learn so much. And more than anything, the packed up humility, you know, the packed up humility and the way Anjali was getting motivated at every step. You know, that's what I learned. I have nothing to add, Kishan. Sir is
Madam, please, from your experience as well. Yeah, you are also, I know, I have seen you. You are more into clinical acumen. You also believe in the same, like sir, see, just with the symptoms. Anjali, how he brought out of everything, just with 2 symptoms, what he mentioned. Everything, just discussion was based on one slide. So Madam is also similar. Okay, I learned from her. She also believes the same. So I want some words of wisdom from Madam as well.
Yes,
Yeah,
yes.
sir was talking to Anjali about persistent symptoms and recurrent, and he did tell her about the paracetamol and all that. Whenever I discuss, I always tell the students how to manage fever. You must tell the parents how to manage fever. It is not paracetamol. The first instruction I tell them is when the fever is high, switch on the fan. And second thing is open the windows. Let there be a good air circulation. Third thing is, full sleeves cotton clothes if the child is feeling very chill or, fever, a cold feeling, then you ask the parents to do that with socks. Give routine bath, because the moment a child has fever, parents don't give bath. Then routine food, 1 hour after fever subsides. For heaven's sake, don't put cold packs. Sir was talking about when you give paracetamol, what happens, how the mechanism of action. So when you're doing this cold pack, you're causing vasoconstriction and fever will not come down. As pediatricians, we are worried about febrile convulsions in the age group of now, though we used to say 6 months, now it is 3 months to 6 years. And next, you must tell the parents that paracetamol should not be given every 2 hourly. There are parents who keep giving paracetamol every 2 hourly. You must tell them once you give paracetamol, it takes 2 hours for the drug to act. In that time, do all these measures instead of going on giving another dose every half an hour. I would like to quote Dr. Anupam Sibal of Indraprastha Apollo Hospital, where he states that the indication for liver transplant is the liters of paracetamol that mothers have given unknowingly with a desire to help their children. So when we talk about, as medical professionals, we talk about fever causes, etc. But at the same time, please address that mother or the caregiver how to manage fever. And also, sir very well told us about the locally acting bronchodilator. I congratulate you, Anjali. And because of you, I got the opportunity to get my favorite teacher, a close friend of my father. And sir has done so much for my father when he had his heart attack. I can't forget it. He personally came with my father and took us to the very famous cardiologist in Bombay. His name was Dr. Sushil Munshi. Sir, I never forget that. I never forget your role in my personal life. Thank you, Kishan. Thank you, sir. I continue to seek your blessings and good wishes, sir.
Thank you, madam.